I had a real fast forward in my first job. I think most of you know Gennady Bratslavsky in upstate New York, and he built a great team there that is really reflective of his roots at the NIH. And soon after the approval of hydrogel spacers in 2015, even way before there was a bill, the radiation oncologist there, Jeff Bogart, said, "Hey, I know you're really into this. You should get into my suite." And this is difficult, when you're starting your practice and things like that, when you're trying to talk to this. It takes visionaries that really see that, and I had this opportunity. So that's one disclosure. I've been doing this for a while. The other thing is we open trials in this too. So beyond the hydrogel spacers and the technologies that we've used in the that are maybe commercially available, but there's a lot of work in this in terms of like balloon spacers and whatnot. So I put this picture up because when I'm explaining to a patient, I'm often like Googling the word prostate, and I hate the artist renditions because look at this gap there that's like a whole football field, right? And it's really not reflective of how this are. And these sort of misinterpretations are, and we all know this because we've been there. We're deep in the trenches where we know there's very little room. And when I'm explaining this to my residents and we're doing that posterior dissection behind and saying, "Hey guys, fat is not your friend," right? Like you're really close. You have no idea how much this matters. And so when we're trying to help our radiation oncologists who have excellent mapping, no matter what, there's no way to avoid the bladder and no way to avoid the rectum. And these are the pictures I show to my patients because they don't really understand, well, why would the rectum matter, right? And so I bring this up for the people that don't have trophies given to them the governor in math, is we have this inverse square law, right? And so just a little bit of distance, a doubling of the distance, 1 to 2 millimeters, divides this by 4 because it's an exponent in the denominator, right? So just a little gap can make a big difference. And so we've clearly developed this way to kind of peek out even a little bit. And I was quite doubtful that this would matter, but the data showed that it could help things. And so here's a picture a week after and 6 months after, and this is how it should be, right? It just disappears. Hey doc, is this going to go away? I often get questions, are the fiducial markers going to be removed? I'm like, no, don't worry about it. Is that going to be okay? Yeah, I think it's going to be fine. Don't worry about it, right? But these, in general, are designed to melt away, or they're bioabsorbable. Is that always the case? Well, maybe not. We'll get to that. And did it matter? I put up the data on GI toxicity because this is the most mature. And there's some emerging data that may be in urinary and sexual that there may be. But really, thankfully, our radiation oncologists have gotten better. And even without the use of these are rare events. But what do? We push the envelope so that even that rare guy, we can't forget. We can treat 100 patients, but if there's one that's sad at home, we think about that one, right? And so really, even at 3 years, we're getting measurable differences in bowel quality of life, grade 3 toxicities, 6% versus 0. These are significant. And so is it worth the time? I think so, because we've all seen those patients, particularly in active radiation practices that are coming in with rectal bleeding or fecal incontinence. These are really devastating side effects. How about the dark side, right? And I think a lot of this, the thing that I think that mild discomfort is super common. They're going to get pressure. They're going to get that almost like an urge to defecate. It's very palpable at the time of placement. I didn't really pick up on this early when we were doing it. The first few, these were often on asleep patients, but we don't do that anymore. We do it awake, under local. These are things that the group obviously pointed out in the last talk. Really emphasized that. I've really had very few failed insertions, but here's the real kicker is this little tilde, and it's always the case. Is are you going to misplace it Is it going to go into the right space? Is it going to go into where it doesn't belong? And, I always worry when you're talking about data from trials. These are often in the most reliable practitioners that know. And then when there's a widespread distribution of this, often we're pushing the practitioner to a place that they're not ready to do, right? So if you're not familiar with the perineal approach, there's a learning curve. Or if many providers that are doing this, they had a limited amount of brachytherapy placement if they're radiation oncologists, and maybe they stopped doing brachytherapy and they haven't done that for 15 years, right? So that's where these things are popping up, and they're really in the wild. It's really happening. You'll see rectal wall implantation has been described, right? And this is something you really have to worry about. Fistula formation, incursion into the rectum, intravascular injections. And then here's one that I think can be very relevant. We see these great pictures of this stuff just disappearing, but there's probably some fibrosis and scarring. And, in the day that radiation was really the last step, probably not really relevant because very few people are going back, right? Very few people tackle salvage prostatectomy. And while it has been described that that's not been an issue, the ends are one. Hey, we went back once on a post-spacer placement, and it went okay, right? But as here's a group that's really tackling radiation salvage and these should be built into our trials. We really ought to be looking for, are there going to be more inflammation? Is there going to be more fistula formation after this? Especially, we have out-of-the-box thinkers. I hear things like, hey, I placed a spacer before cryo so that I get a little bit more reach. I've heard that in the community, and in this such community. So we're going to have to think about that. So clearly, rectal spacers have the potential to improve the lives of our patients undergoing whole gland radiotherapy. And then technical errors in placement, which we see, and you can go to the FDA website and you can see it yourself. These are really popping up where the gels are not ending up where they are, and exploring maybe safer ways or more reliable ways that can do it. I don't think that this is the crowd that we have to worry about, but as it hits, when the rubber meets the road, we're gonna see more and more of these. And we're gonna have to help our patients through it. So thanks.